The way a country regards health and cares for the sick is a measure of the society in which we live. Class, power structures, economics, industry, and environment are all factors that have their effect on health. Both health and illness touch upon all aspects of our lives, regardless of who or what we are. They can't be separated from politics and history. Since the beginning of the National Health Service, the organisational problems and spiralling costs have produced from a succession of governments a rash of reorganisations and reviews, not just of the NHS, but also of community care, the welfare state and the social services. With treatment freely available to many people for the first time, the NHS was swamped with people's needs. Both the continuous pressure on resources and the curative bias of medicine discouraged any serious measurement of resources and need, or even of prevention to reduce need. The continuing dilemma of demand versus resources obscures fundamental questions of what the role of the NHS, local authorities, and the community should be, and where responsibilities should lie. A health system, to be effective, needs not just to cure illnesses, but also to prevent them and to provide care services. Where a system cannot cure, it needs to care. It can relieve pain and look after those unable to look after themselves. What perhaps the National Health Service does best is the least valued part of its work. Caring for the long-term sick, the elderly and the disabled are the most poorly resourced areas of work and carry the lowest status.
I believe there's very little wrong with our health service. I believe it's ideal, that it's centrally funded by government, that it's available to anyone, regardless of race, sex, or where they live, and it is freely available at a time of need. That's the pattern, and it's a very, very good pattern. It's run on a shoestring. That's what's wrong with it. It needs more resources in almost every branch.
I don't think there are any fundamental structural defects, although I do think that the services and this framework should be developed and improved. At the moment, people are blaming the system for faults which are caused by the funding problems, which are the fault of government.
I think the NHS was one of the great developments of post-war Britain, and we are thoroughly committed to the NHS. It's often the subject of political debate to say that we're not, but we are, and I believe the record shows that we are. I say that as a prelude then to saying that I'm quite sure, and it wouldn't be surprising about any thought that someone had in 1948, that not everything that they thought then has stood the test of time. I mean, there was an assumption then. Founding fathers, the NHS thought that once you had a good system to which everyone had access, in effect the system would work itself out of a job because people would become healthy and would not require the system so much. We know that, of course, that far from being the case, that the demands that are placed on the system are growing year on year, inexorably.
At the end of the Second World War, the organisation of the medical services formed the basis of the National Health Service. Public debate and pressure had continued for many years before the war, demanding significant changes of the medical sector by the state, as well as social and economic policies to improve living conditions for the poorer sections of society. The debate was centred on free health care for all and the integration of prevention within the curative services. Doctors would become salaried state employees on a full-time salary, and private medicine was to be abolished.
The men and women of the armed forces do not require further incentive to do their utmost, but they will go into the struggle renewed in heart and vigor if they believe that a fuller life, a better Britain, await us all after the war.
The security plan in my report will deal with want and with some extent with disease. But there are other giants to be killed as well.
The publication of the Beveridge Report, the wartime founding document of the National Health Service and the welfare state, caused much public excitement. It predicted that the falling birth rate and the increased life expectancy of the population would create an imbalance between those able to work and the elderly who would be dependent on the state. Those who worked would create the revenue to provide for those unable to work through illness or age. But the scheme was not welcomed by everyone. The British Medical Association and some health professionals felt their freedom under serious threat.
What do you feel about the suggestion that private patients should get free drugs on the national health?
It is not a suggestion, it is the patient's right to have free drugs. And it is BMA policy to campaign until that right is granted.
If a government were to interfere with your treatment, then you would be prepared to strike.
Oh, now let's get this quite clear. The doctors would never strike. They must always and would always go on treating their patients. But it might happen, as for example the point I made in my last answer, if a government started interfering with a doctor's treatment of patients, in the patient's interest, doctors might feel compelled to withdraw from that particular service organized by the government and give a better service in another way.
A long battle began between the profession and Aneurin Bevan, the new Labour Minister for Health, which led to the eventual structure of the service being determined by the medical profession, which ensured their cooperation. Doctors, dentists and opticians kept their freelance status, and private medicine was retained. Hospitals were managed by committees on which consultants and specialists enjoyed strong representation, and teaching hospitals kept their independent status whilst receiving state funds. Resources and power remained with the hospital sector and defined the caring role of the NHS as curative and hospital-based, leaving local authorities with fewer resources to manage the preventative and community services. The power struggle had been at the expense of the public health sector and ultimately the users of the health service.
Well, the NHS was set up not as a planned system. The NHS was set up as the nationalisation of the existing network of hospitals, largely, with the hopes that if sufficient resources were available, if actually the pool of illness could be reduced, and actually instead of being an expanding commitment, it might actually be a reducing commitment. This was some of the initial thoughts on the question. Never was there a full sort of reckoning made of the levels of need and demand for the service from the very outset, and it still isn't the case now. Health authorities make guesses based on population projections as to how many patients will need a given form of treatment. And those guesses are then drawn into plans which may or may not be carried out according to whether there is sufficient cash available. And the cash is determined by government at top level on the basis of how much they're prepared to put into the NHS, not on the basis of how many patients need treatment.
All governments are unsympathetic and do not listen. They do not allocate sufficient resources, whether they are Conservative or Labour, to the health service. And there are graphs which show that whichever government's been in power, we're at the bottom of the league. It's not party political in that sense. It's when the governments are in opposition, they will promise voters the earth. When they actually have to deliver them, they can't, without putting up taxes, and that they won't do.
Spending cuts and reorganisations under both Labour and Conservative governments resulted in a series of low pay disputes in the 60s and 70s, and later in hospital and ward closures. The difficulties were compounded by an increased number of managerial staff overseeing a static workforce who were facing a heavier workload. The responsibility for community services was returned to the local authorities, who also faced cash limits. The integration of community care and the role of the family in individual welfare were ideas first raised during the last Labour government.
Answer the question!
Because the acute sector grabs all the headlines, the consultants in that sector have been able to entrench a very strong position whereby they defend their patch, they defend their specialities, and particularly the kind of high-tech specialities, the kidney dialysis and all this type of thing, which you hear about all the time, and there are appeals in every pub, buy a kidney unit, and people go jogging to raise the money. What you don't hear about is the less glamorous side, the geriatric care, and so on. Those consultants don't have the lobbying power. And so when you're looking at further diluting that, in fact, the turning from hospital care for the chronic sector to a community care, which again dissipates people over a much broader sort of area, in which the consultants themselves actually lose some of the control, then it's much harder to press the case for adequate funding.
If you've got somebody in a hospital, you've got all the relevant services there in the building. If you've got somebody out in the home, all the relevant services are run by different organisations, the local authority, the education authority, the community services of the health authority, the Meals on Wheels, the voluntary agencies like Age Concern, the mental health associations, the GPs, who of course are self-employed. We've got our own employing organisations through the family practitioner committees that have some difficulties in working with the health authorities. It's all very fragmented. The organisational problems are very great, and the financial problems are considerable.
She was desperate to be at home from hospital. He even joked about them needing the bed. Oh, the last nursing I did was when Father died. I swore then never again. And here I am, waiting on a doctor. I didn't mean to leave her this long. She shouldn't be alone. All this time just for a few tablets. What have they been doing in there? Instead of time, he's giving them pills. Well, I'm all for progress, but some of them seem to do more harm than good. Except for those that make them, of course. It'll be at least another hour before he's seen all of this lot.
Well, one of the great boasts of this present government is that the hospitals have become more efficient, as they put it, because they're treating more patients in less beds, and the turnover of patients is increasing. One of the figures that they refuse to give, and they will not measure, is the number of patients who are subsequently readmitted to hospital because they've been discharged too quickly, or because having been discharged home, there's nobody to look after them and there's no support services, and they injure themselves or they suffer a relapse.
Care in the community is the new in-word, it's the new way of doing things, and of course financially it makes sense because it is thought that it would cost less, certainly for the hospital service, if people are cared for in the community. Unfortunately, all experience shows, and even some little research has been done, shows that looking after people in the community, who can be looked after in the community, instead of in a hospital, costs a lot of money, possibly even more than looking after them in hospital. And certainly the organisation is much more difficult.
I always said you should take things easier. Rushing around, taking on everybody's problems. But to have a bad heart at your age. I thought you'd end up looking after me. Now I'm all you've got. Families should stick together and look out for each other. With all that talk about marriage and families a while ago, you'd think people would want to hold on to the good things. But nothing's different. No one's changed. No one was listening. People are out for themselves. As if they're afraid. But what of? They don't know when they're well off. I've never asked for charity in my life. She's always paid her dues, and now when we need help, they leave us waiting. I'm trying to care for her, and all I can worry about are my savings.
If you look at the way community care policies have been formulated over the last few years, it's quite clear that they've been based on a myth, that they've been based on the myth that society consists almost entirely of little nuclear families out there in their little houses, in which the mother, a very central figure, has an infinite amount of time and energy to devote to caring for people who need to be cared for. Now, obviously, that's been a very powerful message which has been put across, and a very convenient message for policymakers, because women's care in the home is unwaged, largely invisible and unrecognised socially. So if you can actually get most of your caring done by people who don't get paid, and who by and large have very little political clout and just keep quiet and get on and do the caring, then that's obviously quite convenient if you're trying to spend as little as possible on things like the health service. The reality, of course, is that most people in societies like Britain actually don't live in that kind of nuclear family. Many people live alone. They don't have other people to care for them. Even when they do live within a nuclear family, the women very often are not in a position to be able to take care of them. The family's dependent on the woman's wage as well as the man's. And even if women wanted to care for their dependent relatives, it's very often very difficult for them to do that and actually survive economically.
You have to look at any individual and say, what is the community for that person? And this is why when you talk about community care, careful assessment by trained professionals is terribly important. You can't just dump people out in the community and assume they're going to get on. And this particularly applies to people with mental illnesses, people who've often spent many years in a mental illness hospital. They may be rehabilitated. They get used to the new money, new coins instead of pounds, shillings and pence. And they're helped to get out into the community. They're given a home, but where's the home? Well, mental health associations and some local authorities do provide group homes, which are very good. But a number of people very quickly find themselves in bed and breakfast hotels. And that's not an environment for somebody who's fragile, who is unused to the ways of the world. And not surprisingly, a number of these people who have had long-term mental illnesses, their mental illness gets worse.
Living in the real world, where there's buses going down the street, there's a post office, banks, shops, where you're actually living within the normal community, has to be seen as a good thing. But one has to balance that with the fact that to learn those skills and to become adjusted to that, it takes a great deal of time and effort on behalf of carers, because people are often living in institutions for a long time aren't used to that sort of thing. So yes, it is an excellent concept, and we must continue to move in that direction, but we mustn't underestimate the amount of resources that are needed to achieve it successfully. And it is so easy for the positive sides of community care to become negative if you do not have the proper support and backup for people living in the big wide world. Then it can so easily become an area of neglect, of unhappiness and of social deprivation.
Well, I don't think we've yet seen the full impact of the community care policies, because in most cases the programmes are sort of beginning and have taken a long time to formulate and are only just beginning to take effect. But I think that the longer term impact will be to cause absolute havoc with social services and with the remaining services in health authorities. And the reason is because community care is much more expensive to provide than the existing forms of care in large institutions. And particularly in the inner city areas, where already social services and health authorities are under considerable stress. They have large numbers of elderly people, large concentrations of unemployed, large problems of poverty, and inner city illnesses and stress, which cause all kinds of other additional pressures on services. And I think under those conditions, to carry out what is a transfer of one underfunded service to another overstretched service is not going to solve any problems whatsoever.
She was always reading the papers. And always saying, I don't ask enough questions. I never saw it as anything to do with me. I have enough problems without worrying about the rest of the world. But I do worry about them sending you home so soon. And I do need to know what I should be asking the doctors. But I don't know what the questions are.
Large numbers of women in the community are involved in caring for other people. And that caring has a very particular quality about it, because that caring is done, first of all, without pay, and I think that has very important implications for women's psychology, their sense of themselves and their own autonomy and so on, their status in society. But it's also done not just unpaid, but also it's done out of, it is assumed, emotion. It's done for love. I mean, women apparently care for other people because they love them. And again, I think that has a very particular impact on women themselves. It puts a great deal of pressure on women in relation to their caring roles, because it puts pressure on them not just to care for people, but to actually care about people. And in a lot of circumstances, it may be even harder to care about people to order than it is to care for them.
There are many people, particularly in mental illness, who don't want to cope with their mentally ill relative. It's a tremendous strain. Some people may want to do it with respite care, so that they'll do it for a little while and then perhaps to have 2-week admissions into hospital or some sort of nursing home every few months. So flexible responses. In some cases there are proper community care setups. Then, of course, the professionals have to come in. And then we are often the people who have the ultimate responsibility. And I find myself again and again saying to relatives, look, it is my responsibility to look after your mother. You don't have to. If you want to, that's fine, and I will support you. But if you've got to the end of your tether, then it is my responsibility. You go away on holiday, and I will try and mobilise the local network.
I think what you'd find if you talk to a lot of women who actually are caring in the community on an unpaid basis is that they actually get a great deal of pleasure and satisfaction out of doing that job. I mean, it would be quite absurd to suggest, and I think it would be quite offensive to a lot of those women who do that caring, to suggest that they actually forced into it, that they actually don't get any satisfaction out of it. I mean, I think many of them give their labour very willingly and feel a very great emotional commitment to the person that they're caring for. What they do feel, however, is that the kind of support which they need in caring, I mean, the whole argument about who cares for the carers, crucially important here, that the kind of support which they could have, both financial support and also support in the way of counselling and help and respite care and so on, simply isn't available to them. So I think a large number of women in reality would actually want to go on caring, whatever. But that their circumstances could be made a great deal better and their own health improved by adequate support and resources being given to them.
The difficulties involved in planning and coordinating large and bureaucratic structures like the NHS the local authorities and central government, all of which are differently funded and differently run, have led to the need to change the way we run our healthcare system. But with healthcare, planning needs to project much further into the future than in any other area. Measuring available care by the ability to pay, or by demand rather than need, or by the resources defined as available, are not simply a question of economics, but of political, social, and moral will.
Of course there isn't infinite demand. People say how awful it is for kidney transplants. It's the major example that people give. But there are only a finite number of people in this country who've got kidney failure. If you were to inject a short-term amount of money into the National Health Service to mop up the waiting lists for kidney transplants, you would then only need a relatively modest amount of revenue to keep ticking over the new cases that came up. There isn't infinite demand. How many people can there be who need hip replacements? Once we've caught up with the backlog, there'll only be the new cases coming on. There are a lot of them, I don't deny that. But it's becoming a routine operation, not very expensive. All we've got to do is just mop up the backlog and then keep the thing ticking over. It is not infinite demand. There's only a finite number of people in this country.
Priorities of spending are decided by government on the advice of the higher levels of the medical profession and economists. Inflation for the NHS runs much higher than for the rest of us, as drugs, new technology, and medical training in the hospital sector take an ever-increasing share of the health budget. The effect has been to increase our dependence on medical intervention, which in turn increases demand. But 81% of patients are dealt with by GPs, while only 3% are admitted to hospital.
Things which are easy to measure, which are usually called hard research, i.e. like birth weight of babies or people dying or whatever, that kind of research gets funded quite easily because people say, yes, well, this is scientific. But things which are much harder to measure, like the quality of life, the sort of nebulous negative side effects on a patient and their family, etc., which is known as soft research, although it's really much more difficult, that's much more difficult to get funds to look into. And that's partly because the very people who are in the forefront of doing these technical advances and therefore seen as the high flyers are the ones who get on the committees which decide about the money.
Those of us who are health ministers spend an enormous amount of time listening to the views of our parliamentary colleagues, to specialist committees in the House of Commons who advise us, to various bodies that represent either general practitioners or that represent consultants or that represent nurses or that represent family practitioner committees and so on and so forth. I mean, I've certainly not found any shortage of bodies willing to give advice in the health field, and I think it's right that they should. And obviously from time to time we agree and from time to time we don't. But I think it's important that a service that is so vital to all of us should be one that everyone should feel they can make a contribution to. And I can assure you, so far as we are concerned, while we beg leave sometimes to differ with the advice that we're given, we take it very seriously.
I don't have a problem with thinking of the health service. I don't necessarily mean the National Health Service. I mean about healthcare provision in Britain as being a business. In every other country in the world, I mean, healthcare is a business, and doctors and nurses and people who run hospitals run it as a sort of business. Yes, we have a vocation as a doctor, I have a vocation to be a doctor, and nurses have vocations to be nurses. But that doesn't mean that we don't want to live reasonable standards of living. And I think one of the advantages of running healthcare, certainly in an efficient and business-like way, is that we don't waste. And after all, we're a bit short of resources in Britain, healthcare, and we mustn't waste any. And I think if one looks at it as a sort of a business, then perhaps we could use efficient management and business methods to deliver more care for the people.
What one is looking to do is to try to ensure that the NHS doesn't stand outside the great advances in management that have been made in institutions in the commercial sector. And one of the things we have done is brought in some good commercial managers, either into a direct management role in the NHS or into an advisory role. I mean, for instance, one of our principal advisors just now is Sir Roy Griffiths, recently retired as the managing director of Sainsbury's. Well, I mean, I think the record shows he knows a great deal about management, and his experience is extremely relevant to what must never become an introverted service, because even though, of course, it's different curing patients from selling groceries, there are certain management techniques that are common to both, and the NHS shouldn't stand outside those.
Why do I feel the doctors weren't telling me everything? Why didn't they admit they just didn't know? When she died, they all acted as if they'd failed. With every new cure, some new disease turns up. And then they say we eat the wrong things. We live the wrong way. Then there are all the other changes. The planet, the air, even the rain. It's all connected. Nothing happens of itself.
The NHS is the largest hotel chain in Europe. It needs proper hotel managers. It has an enormous amount of building and land. It needs professional property runners. It is the largest employer of labour short of the Red Army. It needs proper personnel managers. But all of them are subservient to the need to treat patients.
The health service is not a supermarket. It's to do with enabling people to be sensitive, to be flexible in response to the needs of human beings. It's not a matter of increasing turnover. And it's this sort of idea that management should be able to make things more efficient is what really gets me. And what I really find perhaps the most irritating thing of all is the misuse of language. That managers are increasingly using euphemisms. They're using words like efficiency savings. That really means cuts. They talk about staff rationalizations as if it's a good thing. That means sacking people.
You buy in services from private companies and you say, well, we're putting this service out to tender. And then you say, well, we have to take the lowest tender. Irrespective then, actually, of whether this company can actually deliver the service or not. So you wind up with a service which is cheaper, which may save you £100,000 a year, but which winds up not actually being the service that you wanted or you had before. So you save the £100,000 a year, but then you have a whole staff involved then in monitoring or complaining or submitting written demands for the removal of the contractor and whatever, and this is going on in many hospitals across the country. Now, is this a saving? Is it more efficient? Is it anything to do with patient care at all? Is it what the patients would want if anybody ever asked them?
A lady from Manchester received quite a shock last year, just 3 days short of her 52nd birthday.
A healthcare system based on the demands of market forces would attract the most money and resources to areas which already have better services and a wealthier population, while the poorer areas, with the least resources and the highest death and sickness rates, would attract none.
Of the operations are done privately. Most people obtain their private medical care through Bupa.
Nearly there. Oh, well done.
Bupa. Britain feels better for it.
I'd like to see private NHS hospitals giving much more private services, because it seems to me they shouldn't be, there's no reason why there shouldn't be different standards of hotel accommodation. I mean, we don't all go and stay in 2-star hotels. Some of us stay in 2-star, some stay in 4, depending on what we can afford or what we want to spend our money on. The same is true of cars. We don't all run around in Minis. Some of us want Maestros and a few of us want Rolls Royces. Thankfully not me, but you know, some people do. And it seems to me that people should have the choice within the National Health Service to have their basic NHS treatment, but to be able to buy extras. And this is a sort of topping up theory, where patients can pay for amenity beds or private beds in an NHS hospital. Or, alternatively, they can, you know, insure and go into a private hospital if they want those sort of standards outside an NHS campus. But it seems to me the way to keep medicine together cohesively is for an NHS campus, an NHS hospital, to offer both services.
Most health care is given to children and the elderly. The working people from about 18 to probably 55 are very low consumers of health care, and they're the providers of the money to provide it for the others. That's why the health service works so well. And those people in the 18 to 55 group are those that the private sector want, because they're high earners and low consumers, and therefore make a profit. Whereas the children and the elderly are high users and low providers, and therefore make a loss.
I'd love to see the very young and the elderly having private medical treatment. And in theory, there's no reason why they shouldn't. But one of the problems is that it can work when people go into an insurance scheme young, because they stay with that insurance scheme, and there's no sort of insurance problems of loading and of adverse selection, it's called, bad risks. If you're in a scheme a long time, then you grow with the scheme. What tends to happen at the moment is that quite a lot of elderly people don't do anything about private medicine while they're young. And all of a sudden, that retirement age think, well, I think we'll join a private medicine scheme now, and get very cross when they can't get in because they've got a list of ailments. Well, that's rather like asking your car insurance to take on your premium for your car when you've already had an accident.
In 1988, the Griffiths Report recommended that a minister be appointed to control and define the distribution of community care funding through local authorities. They would then buy, but not necessarily provide, the services. Central government funding would cover up to 50% of the costs, and social service authorities would be expected to stimulate the private sector. The provision of care would become means-tested, and there would be an increase in the numbers of people paying for services from private pensions or insurance, or by drawing from their savings.
Well, the Griffiths Report, in our view, is a package designed to shed a large percentage of the present caseload of the National Health Service into, effectively, the private sector. The idea is, of course, that many of the elderly patients, and Griffiths is mainly talking about elderly patients, would no longer be eligible for long-term care under the NHS. That would basically close down. And they would therefore be pushed into the local authority sector or pay for their own private care in residential and nursing homes. Now, when that happens, they will go out of the free care that they get in the NHS and be subject to means testing. And this potentially, obviously, is a very big on-cost for many elderly people. It means that many would be forced to sell their homes to pay for their own treatment. Many of their relatives would be forced to, otherwise to find money to pay for their care. And the long-term view in Griffiths is to look towards a system in which those people of working age are obliged in one form or another to make provision for their own care when they're elderly as well. So this means private insurance schemes or whatever for people of working age as well. It's an all-round attack, in our view, on care for the elderly within the National Health Service.
Today, over 70% of the population live to over the age of 70. And we want that to happen. But as you say, it has a cost. It has a cost, and it's not just a cost in high-tech care, it's just a cost in the sort of running repairs that people need and the increasing needs that people have when they're older. I mean, people sometimes forget that the health service isn't just about hospitals, nor indeed is it just about family doctors. A lot of it is also about areas which I'm responsible, like the personal social services. It's about domiciliary help. It's about these difficult decisions we have to take about what steps we should take to allow an elderly person who's perhaps getting a little infirm to stay on in their home in the community, or whether we should make it easy for them to go into some form of residential care. And these are difficult decisions, and these are decisions that will become even more difficult as pressure will grow on all of those services.
By the year 2000, the number of people over 85 years old is expected to double, and those over 75 to increase by 35%. The elderly are the highest users of the health services and the most dependent. An estimated 1.5 million women care for the elderly or disabled relatives at home. Of these carers, 80% receive no assistance whatever from community nurses, health visitors, GPs, or from other members of the family.
And one of the difficulties with developing effective community care policies is precisely this, that we're actually working with nuclear families, with small groups of people, in a situation now where both the male and female partner, usually a husband and wife, are actually involved in work outside the home. That the traditional idea of the mother who stays home and looks after children and anybody else who needs looking after is no longer a valid one, that most families actually consist of 2 working parents. And obviously that's had a tremendous impact on the amount of caring resources that are actually available within the family.
The family doesn't live so close together anymore. In this age, travel is easier, I suppose, but also, particularly since there's been unemployment, families are broken up because they've gone to new towns for either jobs or housing or both, which is, the case with my children. Most of them have moved out of London, so that even if they wanted to care for me or my husband, they're several miles away.
Well, all my family's scattered. I haven't got anybody around now, and they're all getting their own places, and they're all in they've got their own troubles. How could they come and look after me? No, they couldn't. They couldn't spend the time on me. I mean, they've got their jobs to do, and if they don't do the jobs, they can't pay their rent mortgage, and then what's happened? So you see, it should be local. The community should... It shouldn't be the ordinary sons and daughters looking after you.
Even in these gardens, there could be no rest. Not even a gravestone to visit. Is that it, Kate? Is that all there is? You said, don't grieve. Don't mourn too long. Don't throw your time away.
My presence is no monument to wasted moments. My history no tally of the dead and forgotten. When monuments split stones and raise rivers, then build them. When words shake the heart, awaken minds, then speak.
It's a measure of how far the social policies have gone wrong, that you're dealing with ever larger numbers of patients each year. The government actually boasts continuously about how they're treating more patients than ever before. You could look at it the other way around. Society is actually making more people than ever before unfit. And, at the same time, we know that many people who might otherwise be classed as patients are not receiving treatment. They're at home or they're just not able to get through waiting lists and get the treatment that they need. So there is a pool of illness which is part of a society that is generating illness.
Health comes down, for me, to individuals being able to realise their potential. I think that's important because you have to take into account the fact that some people are always going to have disabilities of one kind or another. So that to actually just talk about the absence of illness or the absence of infirmity or the absence of disability is going to exclude those people from the definition of health. What we have to be talking about is the creation of a society where everybody is able to realise their potential to the maximum possible extent.
Only one person, alone. What can I do? She said, if you want to do one last thing for me, then do something that matters. That means something to you.
Once people have an expectation, they also believe it's their right. Now, the right involves being able to pay for it, not as an individual, but as a society. In some societies, of course, it means the individual can pay for it, and I totally disagree with that and reject that, because that produces inequalities which are totally unacceptable. But an individual doesn't have a right to expect a degree of care that society can't pay for, in my opinion, for everyone.
You know, that we needed something that was not charity, that was our right. And I personally have never looked on it as free. I don't regard it as free, it's paid for, either in your tax contributions when you're working, or in some other way. But I think that good health care, in a way, would save the country money. The mere fact that people should be encouraged to keep healthy would save hospital beds, or in the question of elderly people who are having to be going to a residential home. I think more money should be spent on preventative medicine. When we're talking about elderly people, I particularly look forward to being 100, but I say a healthy, happy 100. Not sort of laying, God forbid, in a geriatric ward screwed up waiting for the end, you know.
If there is no such thing as society, if the individual holds sway, who then will hear the quiet voice, the voice of the elderly, the sick, the disabled, and those who care for them? The debate cannot be left to others. Illness and health are personal experiences, and in our own experience, all of us are experts.
People who work in an employed status, particularly in hospitals or anywhere for that matter, are always a bit wary about what will happen with their employer's view of what they're saying or doing. We're self-employed. We can speak out, and I think we should speak out. When we see injustice in front of us, we have a freedom to speak out which is rare amongst people of the sort of social class that GPs tend to be. And I think we have a duty to speak out on behalf of people who haven't got the power to speak out for themselves.